Hello, everyone, and welcome to the medDesign podcast, where we explore the journeys of medical innovators. And this week, we have a true healthcare leader with us, Dr. Spencer Dorn. Dr. Dorn is a gastroenterologist with over 17 years of experience in the field. He is currently the UNC Department of Medicine's vice chair, where he enhances existing care processes to better meet the needs of the population served by the department's over 600 clinicians. As a physician, he cares for adults with acute and chronic GI conditions and has a special focus on functional GI and motility disorders. Dr. Dorn is also a lead informatics physician working to optimize the use of the Epic electronic healthcare record. He has also co-developed applications to improve scheduling and test result communication, really reflecting his deep interest in using digital health technologies to solve tough problems. His expertise in clinical care, academic medicine, and digital health, Dr. Dorn is really a true asset to the healthcare industry. We're really honored to have him on today. And just welcome, Dr. Dorn. We know you're one of the busiest people we've talked to.
No problem. I'm not that busy.
Let's see. So let's get this started off with just talking about what motivated you to go into medicine initially and then subsequently into academic medicine.
Yeah, I say this kind of jokingly, but it's actually the truth. I have an identical twin brother. When I was like 6 or 7 years old, our father said to us, you could either be a doctor or a lawyer. He became a lawyer. I became a doctor, how it worked out. But I feel I chose to become a doctor. I've had a lot of good fortune and a lot of guidance along the way. And I started with my father, who I don't know if he was kidding or not, but he certainly wanted us to get a great education and contribute back. But I've always been interested in people. And I liked science, I guess, like most pre-med students do, but it was more the people, being able to work with people, serve people in meaningful ways that really attracted me towards healthcare. And I've been fortunate to wind up here.
Also, just curious of gastroenterology as your specialty. Why did you choose that over others?
Yeah, so I guess similarly, when I was in medical school, I realized I wanted to work with people with direct frontline patient care. I was interested in working with people with chronic illness, and I just really liked internal medicine. I chose that as my residency because it just seemed like a nice way to serve people with chronic illness. And while in residency, I realized I wanted to become a specialist. I like to have focused knowledge. I like to, I guess, master what I'm interested in. And gastroenterology really called out to me for a few reasons. One is that's a very varied discipline. As you mentioned earlier, Jared, we do acute illness, we do chronic illness, we take care of people in the hospital, outside of the hospital. We do procedures, and we also do purely cognitive work. So it was a nice blend there. And then second, and really what brought me to UNC was my interest in mind-body medicine and how the mind and the body are intimately connected, and perhaps nowhere more so than the gut. We've all had butterflies in our stomach if we're nervous about something, or we use words like we have an upset stomach, right? We just feel a lot of emotion and good and bad stress and a lot of things in our bodies, but especially in our gut. So that was really what attracted me to gastroenterology specifically within medicine.
You actually brought up a really interesting point that I wanted to bring up next as well. So you talk about your approach to integrating body and mind in patient care. And for myself, someone that works on trying to quiet my mind for that same reason and through meditative practice, and where would you say that the mind has that impact on the body? Also, just for your patient care as well, how do you integrate the two? How do you treat folks for mind and body?
Yeah, like you said, the mind and the body are intimately connected. They don't live in different rooms. They're the same side of, or different sides of the same coin. If we're not feeling well physically, we'll feel unwell emotionally. If we're not feeling well emotionally, we'll feel unwell physically, and vice versa, right? If you ever step out of a hot tub, your body's all relaxed, your mind is really relaxed. Why? Because your muscles are all relaxed. And there are plenty of examples of that we all experience in daily living. Try to bring that aspect to my clinical practice, where I work specifically with patients who have what's known as disorders of gut-brain interaction, what used to be called functional GI disorders. These are conditions like irritable bowel syndrome and gastroparesis and cyclic vomiting syndrome. These are conditions that often have no structural basis on tests. So we do tests on people. Usually other gastroenterologists have done tests and they all look normal, yet the person's still suffering. So they wind up seeing me eventually, some of them. And I try to, one, just bring an openness to discussing and understanding what it is that they're experiencing, not only their symptoms, but how their physical symptoms is actually impacting the quality of their life and what their main concerns are and what they think is going on. So I think a lot of it comes to listening and then trying to probe and see, do they see a connection between other factors in their life and their physical symptoms, or their physical symptoms and other factors in their lives, and letting it develop organically. You can't force those types of insights, but I've discovered that most people have some awareness of the role that the body is having on the mind and the role that the mind is having on the body. And with that awareness, there's opportunity to explore and to try and work on both, right? To try and work on both to reduce suffering and improve health.
This brings up a memory of mine when I was in college and had a lot going on in family and work in school. And I started to have all these physical symptoms that were popping up. And of course, I was on the internet, I was on WebMD, and I had found all these illnesses that I had self-diagnosed myself with. I went to the doctor and I was like, all right, I have all these symptoms and I'm pretty sure I have all these illnesses. And they did all the tests and they were like, how's your stress levels? How's your mind? And I didn't even think of that. And that's actually what we ended up treating more so than any other physical symptom. And of course, it turns out that general anxiety disorder was somewhat involved in those physical symptoms. And so often in your practice, would you say people maybe fall into that trap as well of self-diagnosing before they even talk to you?
Yeah, it's interesting. I've been thinking a lot about self-diagnosis because the first wave of self-diagnosis was Google and WebMD and those types of things. And of course, now everyone's talking about large language models and generative AI and ChatGPT. And you have to imagine that there'll be even more self-diagnosis when the tools to do so get even better. And sometimes that may be a good thing, right? And democratizing information and assuming the information is accurate and not hallucinated is the jargon we're using. But sometimes it could be challenging too, right? If you have an ordered list of potential diagnoses and it's almost certainly number 1, but number 10 is something horrible and it's on the list, but it's super unlikely and you're reviewing information out of context. And that can, I think, be very stress-provoking. It can lead people down the wrong paths. Not to sidetrack too much, but my general feeling with technology is we use these tools and sometimes the tools are great for what we're trying to do. Sometimes they're not. And we have to be very mindful of the tools that we're using and both the pros and the cons of using the tools. Sometimes a type of tool could be great if you're worried you have strep throat and it's very basic, couple days of sore throat and maybe a little bit of swollen glands, and go on this little symptom checker and tells you, it's likely to have it, or maybe you don't, fine. It's not going to be too stressful. But what if it's something more serious or more chronic? I don't know if I answered your question, Jared, or if I just started sidetracking us.
You're bringing up an interesting point, which is you've got some tools that you can have a discrete logic to them, where you have some kind of electronic patient-reported outcome, like process for do you have COVID or not, and you go through a decision tree to then help impact a broader population health. But then, as you're describing it, where like the mind-body connection between brain and gut, and how complex that is from a diagnosis standpoint, where it takes a little bit more empirical work in order to arrive at some kind of diagnosis. That seems like the kind of thing that the technology tools are a long ways off on being able to support. Is that an accurate take on things? Or?
Yeah, I think that's right. I think that, the chatbots that are in existence today are largely deterministic, right? It's simple programming. If A, then B, very linear. And you can't program the whole world like that, right? I think that's the major breakthrough with machine learning neural networks, is it finds patterns that you can't program every possible scenario, whereas these language models just probabilistically can suggest what the next step is. So I think the challenge is twofold. One, it can be very useful at times. I'm not one of these physicians who says, no, there's no use for these technologies. It can often be very useful, but again, only in the right situations. And then two, with regards to your question, Ty, not everything could be coded very clearly like this. There are a lot of subtleties and nuances and areas where we don't have clearly mapped out understanding or evidence bases or literature, that if we try and apply these language models to those areas, I think we'll get wrong answers because there's not enough there to actually do the work. Going back to the strep throat example, language models should be very good at diagnosing whether a sore throat is likely to be strep or unlikely to be strep, or COVID symptoms, as you mentioned. But certain other things, I think it could be detrimental trying to apply large language models to different areas of medicine that are maybe perhaps less well understood, more nuanced, et cetera. And then, of course, it's delivering. It's not just uncovering the pattern, but how do you explain the pattern? And machines can certainly explain things. We're social beings. And often, I believe, a lot of the art of medicine and the benefit of medicine is through the human connection. Again, you don't need it for managing strep throat necessarily, right? You don't need some deep human connection. Just go to an urgent care doctor or doctor online and get what you need. But for some things, especially the conditions that I help people manage, I think human connection is really important.
Absolutely. I did want to talk about the healthcare system as a whole, but we've been talking about digital health already, so maybe let's talk about that. We just want to get your opinion on what really is digital health to you. How do you define it? And like, why is it important for patient care?
That's a great question. Everyone has a different definition of digital health. I think the World Health Organization has one that some people consider the standard, but digital health means so many different things depending on where you're coming from. To me, digital health are a set of information technologies, right? This is not hardware necessarily. This is not like an implantable defibrillator. That's not digital health. That's a device. It's more information technology, whether it's something like we're doing now, information technology that allows us to communicate or access information or apps. Electronic health records technically are digital health. So it's any sort of, in my mind, information technology that allows us to either allows patients to better serve themselves and allows clinicians to do their jobs, hopefully better, or allow the two to communicate more easily. That's how I see digital health from a relatively simplistic framework.
And I know part of the system that you've worked on directly is the Epic Health Record, right?
Yeah.
And so what was the problem that system is solving? And where is it at right now as far as implementation goes?
Epic is certainly the largest electronic health record being used in health systems, not necessarily in community offices, unless they're part of a health system. And when I started practicing, when I was a resident just out of medical school, we were using paper, right? We were using paper for writing our notes on paper. Well, the notes were hard to read because I write like a doctor. It's really hard to read my writing. So one challenge is the notes were hard to read. Another challenge was actually getting the note, right? Like you couldn't access it from anywhere. You had to go to a physical location to open a physical binder and look through, and information was less accessible. It was less easy to share information. That was one challenge that electronic health records solve, is that it makes clinic notes more easily accessible to others. It's caused other problems, by the way. Like a side effect is our notes are often now bloated with extraneous information, and sometimes there's a lot of nonsense in there. So they're more legible, more accessible, but sometimes harder to actually understand. But that was one problem that electronic health records did solve for, is making clinical information more easier to access. The same holds true for laboratory results and imaging study results and a whole host of other types of information. A second problem that electronic health records help solve for is a lot of the business aspects of healthcare, things like scheduling and registration and insurance verification and billing and collections and all these other aspects are related to the processes and business of healthcare. Electronic health records help solve for as well. The challenge with electronic health records is they're not optimized for one task specifically. They're kind of all-purpose type technology that, at least for Epic and large health systems, that has to do so many different things. So therefore, so often individual users are not thrilled with their own face of that application because it wasn't built necessarily just for them. But the things that Epic and similar systems do well is it does a little bit of everything, and it on some level integrates all these different activities. So if I write a clinical note, that could then go to a billing team who could drop the right charge, and there's going to be a revenue cycle management system that will keep track of that charge and when the revenue has come in. So you could see how it serves various different functions.
Is there maybe an evolution of the current system that we have now that maybe you would look forward to down the line, maybe like 10 years from now, that obviously right now Epic is working, it's up and going, and your practice technology's evolved over time already?
Yeah, the challenge is there are a lot of sunk costs. Health systems have spent literally hundreds of millions of dollars investing in these systems. And these are all purpose systems that do a bit of everything, don't necessarily do everything really well. So I think it's unlikely we'll move away from these in the short term. But thinking ahead to what's possible, what do we need? We need better ways of managing information. Most clinicians, nurses, staff are overloaded with information, just like you're probably overloaded with email and texting and Slack and all the other communication channels you personally use. Same thing on the healthcare side. And there's tons of different types of information that's flowing in: test results, patient requests, notifications of appointments. And there's all this information that's just bombarding the inboxes of clinicians. And it's just very hard to keep up with. It almost becomes its own job in itself. It's really sped up the pace of medicine. And not that these challenges didn't exist 20 years ago. I just think they did, but they're magnified now, and everything's a lot faster, just like the rest of our world is moving a lot faster as well. Ideally, as we move forward, we'll mindfully design tools that help sort out signal from noise. Like, this is something you actually have to pay attention to, this isn't, and hopefully help streamline and or automate a lot of the tasks that are very time consuming, that don't necessarily need a physician or a nurse or even any type of person to do. So I hope that's where we head.
It seems like in the future, there might be some sort of AI bot assistant that handles quite a bit of that for people.
There already is. It's already under development in many different capacities. Machine learning is being applied to a lot of this already by Epic and by other startups and vendors. So yeah, I think that's where we're heading.
And it seems like the process for creating the electronic health records hasn't been very human-centered. And case in point for that, at one point in time, there was the triple aim, which is around experience of care, per capita cost, population health. And then it seemed like, as one of the articles I was reading, was that as electronic health records came out, that there were so many follow-on problems, they expanded it to the quadruple aim, which is we needed to think about the provider's satisfaction because of how onerous all of this data gathering has been put upon the providers. And they're just wondering about the opportunities there for not just adding AI into the mix, but making it so that it's a more curated and human experience that gives just the information that's needed, not necessarily gather all the information and put too much burden on the providers and staff and everything.
Entirely. And as a design thinker, you would be amazed if you saw some of the user interface that's often used far behind what you use in your daily life. This Zoom call is pretty easy for us to do, right? The technology is very usable. It's very simple and streamlined, but a lot of electronic health records, their information's hidden or put in fonts that are hard to read, or too many clicks to get to what you need to do, and the workflows are very complicated and cumbersome. That's one aspect, just from a design and a usability perspective. But then, as you mentioned, a lot of these systems were developed with a lot of bolt-on. So they started with one product, and then they realized there was a need to satisfy some other demand somewhere else. So they're almost like Frankensteins in a way. All these parts get added on, and they may not flow well together. And they're also often built on a very old technology chassis that could be decades old. So it limits the design possibilities now. There's a lot of what economists would say is path dependence, right? These decisions that were made 20 or 30 years ago are still affecting the design today. I agree, and I'm hopeful that we can find ways to bring design thinking and more human-centered design into improving these systems. Not that physicians or nurses or schedulers, not that they've been completely ignored, because these have been built in partnership with them, but there are challenges. And another thing I'd say is healthcare is one of the few industries where we've digitized, but we haven't necessarily experienced the full benefits of that digitization. If you look at healthcare, RAND, which the big think tank RAND in around 2005, I believe, predicted all the cost savings we'd have if we just digitized healthcare with electronic health records. Guess what? Nearly 20 years later, we've yet to realize those benefits in terms of cost or quality or safety. So we've done a lot of work and there's been a lot of investment, but we haven't necessarily reaped the benefits of that, in part because of the design of the systems. It plays a large role, I think, in that.
To that end, the costs of healthcare have been skyrocketing as far as industries go. I mean, it's like the number one, number two industry, in addition to like education, that have just had skyrocketing costs associated relative to the value I think the U.S. population receives in terms of overall population health.
I think it's close to higher education. If you look at how much college cost 20 or 30 years ago compared to now, it's even compared to where you and I were in school, it's incomparable. And it's similar, it's just year after year outpacing the cost growth, outpacing inflation. Part of that is due to design issues, but there are clearly many other factors playing a role.
You make an interesting statement on LinkedIn where you talk about that you literally work in the belly of the healthcare beast. So in what ways is the US healthcare system a beast in some ways?
I think it's a beast in that no one would have designed the system that we have today. If you started from scratch and first principles, you would not have built what we have. And I'm not saying any one specific healthcare system. I'm saying the system, the overall system would never have been designed this way. And I'd also say that individual healthcare systems, regional healthcare systems, local community systems, even many small offices probably wouldn't be designed the way that they're designed right now if you could start from scratch either. So I think that's what I mean. The healthcare system is wonderful in many ways. If someone has needs and if they can access the right care and they're fortunate enough to be guided in the right direction, there are amazing possibilities for improving lives, for saving lives, for extending lives. Everyone's ready to beat up on healthcare. I'm not one of those people. I don't think we should. I think this is just the circumstances that over years of organic development with certain decisions that were made at different points in time. For instance, the decision to make employer-based insurance tax deduction, that's a massive decision that was made many years ago that's influencing so many aspects of our system. There's so many of these decisions, large and small, that have been made over years by government regulators, individuals, health systems, that have affected where we are. And that's why we have the beast. That's why we have a system that often is too inaccessible, is inequitable, does not deliver the value, as Ty said, that ideally it should. So the healthcare system in many ways is wonderful, but in many ways it isn't. And when you say the belly of the beast, just because I'm a gastroenterologist, so I guess that's why I put it on. It's got a little play on that.
Yeah, and when you think of accessibility and affordability, especially with specialty care, for example, I don't really think that the first thing that patients think of is it being necessarily affordable. And so how do you think that we can, in the future, work towards making specialty care more accessible and more affordable, more equitable?
Yeah, so this is something I'm very interested and passionate about, is specialty care. As a specialist, as someone who's operated specialty practices and now works assisting multiple specialty practices, we need to make specialty care more accessible, more affordable, more effective. And if you look at what's happening nationally right now, there's been a lot of emphasis on primary care, as there should be, because primary care is foundational to good health care and good health. Primary care has long been neglected and underfunded and underinvested in. So I applaud all the primary care efforts that are happening right now, and I'm sure you've read about many. But specialty care is often where a lot of the costs accrue and often where the sickest people wind up. So we have to simultaneously improve specialty care. And in my mind, again, this goes back to how do we design care? Right now, we often have one-size-fits-all models. For instance, if someone has mild heartburn or if someone has severe Crohn's disease, they get referred the same way to a gastroenterologist, and they wait just as long to see the gastroenterologist, and they see them in the same office with the same personnel and the same resources. It just doesn't make sense, right? So we have all these one-size-fits-all models where people really have individual needs and preferences. So I believe we need to redesign care in ways that are better tailored to individual needs, not necessarily millions of different types of care, although that would be nice. But let's at least start with 5 or 6 different types of care for newly referred patients that align with their needs and align with their preferences. And I think that will get us much farther towards improving health, towards making care more accessible, making care more affordable. I think that's the direction we need to go into. More models of care, identifying what the needs and preferences are, developing an operating system that matches people based on their needs and preferences to the right type of care for them. Hopefully not too abstract. Hopefully that makes sense.
I mean, you brought up one size fits all as the default for trying to design some of these systems, which think about from a bell curve standpoint, you're trying to capture like the 50th or 60th percentile, where oftentimes from a design thinking standpoint, we're more interested in the tail of the bell curve.
Yeah.
Because those are the places where, like on the 5th percentile, 95th percentile, really small population specialty disease states, those are the points in which the failures in design occur. Because the median is going to be just fine, but it's on the tail end of somebody who's very large or very small, who like has varying levels of ability and mental abilities. Those are the people who are going to be most impacted by failures in design. And the people who, as many of the tails as you can design for, is the term was universal design back when I was going through school. But those are where you try to make sure that the overall system doesn't fail. And it's trying to get away from the one size fits all approach.
Completely. Just to put this in kind of real terms for your listeners, someone who's really sick, someone who has really severe illness, complex psychosocial situation, whatever it is, major needs, if they come into the traditional doctor's office for a 30-minute visit for a doctor working alone, not on a team, it's a major mismatch, right? There's only so much that could be done in that 30 minutes by a physician working by themselves with someone who maybe has multiple chronic illnesses, complex psychosocial situation, etc. The flip side, what happens when someone has a very mild condition and they're sent to a hospital system and they wait a long time? So someone with mild, let's say mild reflux, someone with mild reflux does not need to wait to see me, does not need to wait months and months to see me in a hospital-based facility. What for, right? Like their problem could be solved, or largely their needs can largely be met much more accessibly, much more affordably, much more conveniently. I think that's something that would, I think, align with what you were saying, Ty, about the tails, right? If you're on either end and if you're forced into the same model, it just doesn't really make sense. So yeah, I think I'm a big proponent of trying to right-size care, and so that people with complex needs are met in well-resourced models that have teams working together, not just physicians, teams working with the right resources to solve the need. And those with straightforward needs can often be served sometimes purely online. A lot of these virtual first companies that have popped up, very good for that, or at least in a low cost, highly accessible setting with the right personnel.
We've been talking a lot about the changes that sort of need to happen, but at the end of the day, we need those catalysts of change to drive it. And so are these catalysts going to be healthcare organizations? Are they physicians? Are they insurance companies? Like, where really do we have to start as a society putting our focus towards to actually enact these changes over time?
I don't know if I'm qualified to answer that question. I do think a lot about healthcare and the system broadly, and then the individual components. I think it has to happen at the grassroots level. Change is so hard, right? No one likes to change. It's hard for individuals to change. Now think about changing organizations of individuals. And usually there has to be a motivation to do that. We had a big motivation with the pandemic, right? We had to quickly pivot away from our decades-long model and move care online, right? So it can happen, but there needs to be motivation to make it happen. Whether that motivation comes from competition, I think that's part of it. If you look at some of the developments, vertically integrated or healthcare organizations that are CVS, Aetna just made a large acquisition last week and keeps acquiring, and Optum, United Health Group. These are large corporations that are now starting to span the entire spectrum of healthcare. Will those organizations force the traditional incumbents to say, we've got to change? Will that be the motivation? Perhaps. Will the motivation be the record levels of burnout and unsustainable practice that is happening right now? Maybe that's part of it as well. Will it be motivation just to serve our communities better? Realize that there are opportunities to do better, to reach more people more effectively. So I think there are many potential motivations, threat-based and opportunity-based. I guess threat and opportunity are intertwined in a way. How do we harness that energy, that need to re-examine what we're doing, and then actually do it, actually change, actually intentionally think about why are we here? What are we trying to do? How can we do it better? So I guess that's, I don't know, a long-winded answer.
No, I love that, because you touched on just grassroots as a driver for change. And I think it's so easy, or so much of like historical success for healthcare innovation has come from some new technology, the invention of the Foley catheter or the pacemaker, that have had such profound changes in just quality of people's lives because they've been able to be a direct technology intervention in healthcare. Yep. And I think what we're seeing is an overabundance of technology in the space, where our entire innovation process is set up to put one more piece of technology into the use case. And that may not necessarily be the right answer. It could be that the right answer is to remove technology, or to like fundamentally rethink how the human beings that are involved in this behave and act in interesting ways. And so that's part of what we've been doing with medDesign, is starting with, let's ask the physicians and clinicians to fully define what are the key problems in healthcare, and then try to pattern match from there to try to find what's the best pathway forward, rather than start with a thesis about a technology. So I think it does come with that shift in mindset and thinking to be able to start making some of these big changes.
Yeah, I totally agree. When we think about innovation, we do tend to think about the Foley catheters and the new devices, and they're critically important. What really saved our society from the pandemic, not to minimize all the suffering that it caused and the loss, was the vaccine, right? It was rapid development of mRNA vaccine technology more than anything else that we did. So those breakthroughs, hopefully they continue to occur. Breakthroughs in treatment-assisted fibrosis has really revolutionized. I'm just thinking of a recent example. It really revolutionized how we take care of people. At least that's what my pulmonary doc friends tell me. So all those things, new drugs, new devices, new diagnostics, critically important. And at the same time, I think we have to think more about how we deliver care, how we deliver those interventions, how we organize ourselves. And I'm hopeful that we'll make progress there as well.
Personally think so as well. I do want to talk a bit about academic medicine, your transition to that from being a physician into academic medicine now. What are those challenges you face that are different from working in a private practice? And I guess, how do you deal with those as well in the new system you work in?
I guess I'd say I've always been in academics. I've always lived my life on the semester calendar. I still do. So I went to college, to medical school, to residency, to fellowship. And then right out of fellowship, I joined in the faculty practice here at UNC. So I've always been in academics, have not lived in the outside world. So maybe there wasn't much of a transition. I'm not sure. I think what's different about academic medicine compared to community practice or non-academic systems. For one is we have several missions. Clinical care is certainly one of the main missions that we do, and it's the one that I focus on most at this point in my career, but it's not the only one. We have people learning with us, medical students, residents, fellows, other visiting people. So there's a big emphasis on education and training others. And so that affects how we run things. And then research and discovery is the way that the mRNA vaccines were developed is based on research that was done at University of Pennsylvania and other systems, both fundamental basic research, translational research, and clinical research, leading to discoveries that ultimately reach the bedside. So I think that's the core difference of academic medicine, is that we're engaged in all three of these different activities and we need to balance them all. How does that differ from regular practice? When a patient comes into an academic system, there may be people that are interested in recruiting them for research studies. Research studies, of course, happen outside of academics as well, but there may be more of an emphasis on that. Or there may be trainees involved in their care. Sometimes when I do GI procedures like colonoscopies, I'm working with a fellow, supervising them as they do it. Those types of things. That's, I think, how academics fundamentally differs. For me, it's a beautiful place to work within because there's just a lot of variety, and especially colleagues, right? You have colleagues who are generally curious and often at the forefront of their field. So it makes it really enjoyable. But it is a little more challenging in some ways because we have to make sure we're attending to each of our missions.
Something you talked about as well was balance. And even before, as well as burnout. And that's something that we've come across a lot as well, talking to other physicians. How do you manage your time? Because during my introduction, you have your hands in so many things right now. And so, as somebody that is as busy as you are, how do you find time to just be a human being at the end of the day and not succumb to the burnout of many of your colleagues, really?
I don't know if I'm as busy as you're stating. I like to think I'm not overscheduled completely. One thing is I don't see patients every day. I have different responsibilities, and those different responsibilities are actually funded responsibilities. They're not unpaid obligations always. So I have time that I can dedicate to my different roles, and I see patients part-time. So my colleagues who are seeing patients full-time have different challenges. They may not have as many meetings to go to or as many proposals to write or people to convince of different ideas, but they have a lot of labs to follow up on, a lot of notes to write, a lot of patient calls to return. So that's really hard. It's really hard if you're doing that day in and day out. And I've just in my career managed to go down a different path that gives a little more variety to some extent that I guess frees me from some of the challenges that many of my colleagues face. I'm trying to help them with those challenges, by the way, in the time I'm not seeing patients. And then I think just self-awareness is important to me, cultivating a sense of self-awareness and knowing what I like to do and what I'm good at and what I don't like to do and what I'm not good at. I think trying to keep balanced perspective of what's most important. I'm certainly not perfect at this, but I do try and take time to reflect and for contemplative practice. Very supportive family. Just feel fortunate that I've been able to do the work that I do. Supportive mentor, supportive boss who's wonderful. So yeah, I think I certainly haven't figured it out. I don't know if any of us figured it out in the modern world, but I guess I've been fortunate to have people helping me and along the way.
Sticking on the topic of burnout, we've seen it on social media, physicians or clinicians talking about they work a shift and they have just so many patients. They can't even keep up with people. Maybe sometimes like in the hospital, they're understaffed. And I've seen this a lot since COVID happened, right? I feel like this has been in the news quite a bit more since COVID happened, but is this a function of the way the system was designed, or is there a shortage of people that are qualified to do this work? Or why is it that there's just so much falling on clinicians and physicians at the end of the day?
I don't think it's a new phenomenon. I think it's just more I think it's more extreme now, and it's more in public awareness. I think if you surveyed doctors in the 1970s and asked how much were they working and did they have trouble going home at night and disconnecting from work and not thinking about the cases they had during the day, and I'll bet a large majority of them would say, yes, this is really challenging work. It's really hard to do. I'm stressed out. So I don't think that's necessarily brand new. I think what's different, and by the way, I don't think this is different from other fields either. I think teachers, that's such a hard job. You hear about burnout in education, and I have several family members who are lawyers, and that's really challenging. People in business, small businesses, restaurants, design firms, right? I think it's not necessarily unique to medicine, this feeling of burnout. And I don't think it's a new phenomenon. I think what's different is, one, that COVID just placed tremendous demands on healthcare, right? It really stressed an already stressed system. And it also, I think, caused a lot of conflict, or at least it raised the tension level when there are people who are being hospitalized with COVID who decided they don't want to get vaccines that probably could have prevented their hospitalization, or arguing with clinicians, nurses about certain safety procedures. A lot of politics, I think, came into healthcare, which should really be a politics-free zone, I think, because we're all people. We all want the same thing. My viewpoint is that. So I think that's one thing. I think being on the front lines during a pandemic, we're all people too. We all have our own fears of things, right? And especially before vaccination was available, working front lines with people who were infected. It's kind of like fire people, I should say, running into burning buildings, right? You do it because it's your job, and who else is trained to do that? But it takes a toll. It's stressful. It's stressful to work in that environment when everyone's working from home and you're there and you're afraid to even take your mask off to eat lunch. You go outside to eat lunch because think of the early days of about 3 years ago when this all started, right? It was very scary. So I think that's perhaps part of it. I think part of it is that life in general is moving faster. Life outside of work is moving quickly, and teenagers are more depressed, and just people are more on edge. The economy, inflation, things are more expensive. So I think that also affects healthcare workers like it affects everyone. And then I think there is a tipping point almost that we've reached with the burdens that are placed on clinicians who largely want to do face-to-face work and help people and have meaningful connection, but yet there's all this digital paperwork and all these regulations and all these requirements make it really hard sometimes to find joy in the work. So I think it's a combination of the in-basket we mentioned before, all this after-hours work, trouble disconnecting. I think it's just a confluence of factors. It's hard to say what percentage of the variance each one explains, but I think there are a confluence of factors that, again, not new, not unique to healthcare, but I think for people working in healthcare at this point in time, it certainly has risen to the forefront. And I think it's a good thing that it's part of the public consciousness. I think the public should understand that this is a hard job that people are doing. They're doing their best, but sometimes it's too much for them. And you want your healthcare workers to be happy, right? It's hard to take care of someone if you don't feel like you're being taken care of yourself.
Absolutely. We're getting towards the tail end of things here. Something I did want to talk to you as well about is physician leadership. And so obviously you are a leader of the Department of Medicine. And I know that must have been somewhat of a transition period for you to now be leading a department versus maybe participating in it. And so what are some of the skills that you think lead to success in a role like the one that you're in?
First, I have great colleagues. I think, and many people have helped me get to this point. And like I mentioned, I'm a very supportive boss who's the people around you, I think, are just so important when it comes to leadership because we don't do it alone. I think humility is very important, admitting you're not perfect and don't have all the answers, but are willing to learn. Empathy, I think, is super important, understanding what people are experiencing, being creative and imagining solutions, and showing leadership in some ways is showing that innovation leadership is probably mostly about showing there's a way that we could do things new and differently that's actually better than what we're doing now. And it's worth investing the energy to get there. I think understanding the problems. I'm fortunate that I practice medicine, so I can understand the frustrations of the electronic health record. I use it too. The challenges of having patient access, long wait lists. I see patients who have waited way too long to see me. I think a combination of those are things that I think that help make a good leader. I'm sure I'm leaving many out, but what do you think?
I think that's it. In my past roles of leadership, I think empathy is one thing that if you don't have that as a leader, people will start to write you off. They're going to start to ignore you to some degree. I've always talked about leading through empathy. And I think also people start to understand you a little bit more too, when you have this like human connection.
Yeah, I think one other thing I thought of, and thank you for sharing that, Jared, because you're right, we're all people. To lead people, you have to be a person, you have to be a real person. I think reliability and delivering is important, right? And a lot of it is showing up and responding to people when they have needs. We're all overwhelmed with email and texts and all that, but actually getting back to people. Communication, I guess, is the other thing I would add, being able to communicate a vision that makes sense in a clear and succinct way to build on what you were saying with empathy.
You think about from a leadership standpoint, there's formal authority, which is the title that you have or the formal authority that's structurally in place. But even within the military, which is heavily regimented, relies upon formal authority, you still have that interpersonal, informal, just what can you do to provide an example to show that you're right there next to the people who are all in this together to accomplish the mission. One of the best expressions I've heard is mission first, people always. That if you accomplish the mission and yet your people are just burned out as a result of accomplishing the mission, that wind up not being ready for the next one, and that you want to get there together. And so it's an interesting balance to be able to strike.
Yeah, I like that. Mission first. Mission first, people always. Is that what it was?
Yeah.
Yeah, that's cool.
Yeah, and I think just tying things all together for those younger physicians that are just getting started, they want to be a department leader just like you. What's the advice you have to give them to follow along your footsteps and maybe even be greater than you were or are?
Oh, yeah. I think one thing is you can't plan everything. I didn't think I'd live in North Carolina, be an academic physician, be a gastroenterologist, do this. I think generally when I meet young people, I advise them to point in a certain direction that they think aligns with who they are and what they believe in, what they want to accomplish, but then be open enough to possibilities for changing circumstances, for new opportunities that come along the way. And I like to believe that I'm continuing to do that, but I think that's been useful. I think the second is to surround yourself or connect with people who you look up to and admire, and not only because they're talented, but because they're good people, because you just in your heart feel like it's someone you want to be around or someone you want to be connected with, because we don't do anything alone. There are always people and circumstances and factors helping influence us along the way. And then I guess a third would be to work hard. I guess it goes without saying, maybe that's expected, but working hard to develop yourself as an individual, to develop your domain expertise, whether it be clinical medicine or leadership or operational improvement or design thinking, whatever it is. I think you have to invest the time and energy and effort to develop the skill set necessary. So those would be three.
To that end, of course, into that medDesign a bit. With the program we put together, and Spencer, we got introduced through a mutual friend and colleague who has been through the medDesign course that we've been offering. That is something that we've been providing as a way for people who are physicians and clinicians who are interested in this path of innovation. We've got a structured course where you practically solve active problems, but then walk through really some of the fundamentals of building empathy, clearly defining the problem, and then understanding what the psychology of creativity is about, then actively proposing a wealth of solutions to then make good choices between. So that's some of what we're doing, and we've opened the program up now to where we're accepting applications for that. Something that's been pioneered through UNC Fast Tracks, and we're excited to see that blossom and flourish. We've had a lot of just interest and excitement in the program.
Anyway. I think it's great what you're doing. And I think bringing this way of thinking, these skill sets that traditionally have not been applied in healthcare or not at least been applied in healthcare organizations, I think it's wonderful. There's been a big emphasis on lean over the years. And I don't know enough. I think I mentioned this when we met, Ty, but someone once nicely described design thinking as the emotional or empathetic side of lean, right? It's a different type of design, and just love that. And I don't know a ton about design thinking, but what I do know, it just seems to really align nicely with process improvement, clinical improvement, innovation, all the things that we've been discussing. Yeah, congratulations on building all that.
Thank you for that. Yeah, to that end, I mean, when you're dealing with complexity, human behavior, and you don't have any data, you have to go create the data. That's really where I think the domain of design thinking shines. Whereas if you're dealing with a known data set where you can run an algorithm against it, then that's where continuous process improvement comes into play. And if you think about lean startup, they're pulling from a lot of the tools from design thinking. And, as you think about like business model canvas, which lean startup uses extensively, is a practical application of this empirical guess and test approach to innovation.
Yeah, that's great.
We're coming up on time. We'd like to thank you again, Dr. Dorn, for giving us an hour of your time. We know that we're in great hands for the future of healthcare. The doctors that are coming out from your departments, thank you for all the work you do, and thank you for your time.
Thanks so much. It was a pleasure to meet with you both.